This next lecture is about the pediatric endocrine disorders. The endocrine system is composed of a group of glands which secrete different hormones. Please review these hormones from each endocrine gland as shown in the picture. These hormones are secreted into the blood and they act on target organs to regulate many body processes. And inadequate secretion or dysfunction of such hormones have long-term implications. Box 48.2 shows a child with an endocrine disorders. As you can see, many endocrine and metabolic disorders are inherited, so education and genetic counseling are important preventive measures. These now are the different endocrine disorders that we will discuss. First is dwarfism. It's the hyposecretion of growth hormone by the anterior lobe of the pituitary gland. If growth hormone is deficient, children cannot grow to full size. As a result, children will remain in proportion but well below the average on a standard growth chart. Possible causes are 1. A tumor, mostly craniopharyngioma, that is embryonic origin. This places pressure on the pituitary gland, causing the hyposecretion of the growth hormone. Second is of genetic origin. Third is probably idiopathic from an unknown cause. Among all these possible causes, hypopituitarism in children is mostly from unknown cause. Assessment findings. A newborn is of normal size and weight at birth. As the child grows, the child may look well proportioned but may be overweight for the height. There is also underdeveloped jaw, abnormal position of teeth, high-pitched voice, and delayed puberty. Remember that a halted growth that is sudden suggests a tumor, while a gradual one suggests an idiopathic involvement. And if tumor is the cause, measures to remove it is necessary to halt the pituitary gland pressure, causing insufficiency of the growth hormone secretion. Diagnostic tests would reveal delayed closing of epiphyseal bones. That's why there is a stunted growth, but they have normal IQ scores because cognition is not affected. Without treatment, most children will not reach more than 3 or 4 feet in height. 1. The children can be given IM, recombinant human growth hormone, 2 or 3 times a week. Growth hormone is usually given at bedtime. This is also the time of the day which growth hormone normally peaks. Because these children have delayed epiphyseal closure, if treatment started early, they will be able to reach a targeted height. Second, some may need suppression of LHRH or GnRH to delay epiphyseal closure. This is to allow the IM growth hormone to act on the bones. Third, other children may need supplements of gonadotropin or other pituitary hormones if these are also deficient, because they are from the same affected pituitary gland. Fourth, if children do not respond to growth hormone stimulation, they may be offered a course of a newer synthetic recombinant insulin-like growth factor 1. This is thought to be beneficial in growth. Fifth, interact with child according to chronological or developmental age and not with physical appearance. They are not mentally incapable. So we need also to encourage child and parents to express their feelings. 6 is surgical removal of tumor if this is the cause, although again in dwarfism, idiopathic is the usual cause. But if ever there is a tumor, also monitor for signs and symptoms of additional neurologic impairment, and it's important to keep careful records of the height and the weight. Gigantism is the hypersecretion or overproduction of the growth hormone, which is the opposite of that one in dwarfism. Like dwarfism, they have the same possible causes, which are a brain tumor, either genetic or unknown. But the most common in gigantism is related to a benign tumor of the anterior pituitary, probably adenoma. Assessment findings: if overproduction occurs before bone epiphyseal lines close, there is excessive growth. The weight also increases, but it is proportional to the height. This becomes evident at puberty. Acromegaly may also occur, but later in life. It's the enlargement of the bones of the head, hands, and the feet. This is when bone epiphyses have closed, when linear growth is no longer possible. If the condition remains untreated, a child may reach a height of more than 8 feet. So management is important. First, if cause is tumor, laser surgery or cryosurgery to freeze tissue is the primary treatment. Since tumor is the most common cause in gigantism, its removal will stop compression of the pituitary gland, causing excess growth hormone secretion. Second, if there is no tumor, irradiation or radioactive implants of the pituitary may reduce excess growth hormone production. This is internal radiation, which also makes the child radioactive. This requires isolation during hospitalization. Third, a growth hormone antagonist may be prescribed, such as pegvisomant, but this pituitary hormone may also affect other hormones, such as thyroid, cortisol, and gonadotropin later in life. That is why this is only given if surgery or radiation is unsuccessful. Fourth, bromocriptine oral or octreotide injection can be given. It can reduce growth hormone production. Bromocriptine is a dopamine receptor agonist, while octreotide mimics somatostatin. Fifth is to address emotional concerns too. It is difficult for a child to always be bigger and taller than the playmates, and this may be distressing for them. Third is diabetes insipidus. It is characterized by a decreased antidiuretic hormone production from the posterior pituitary gland. As a review, ADH acts on the kidneys. It conserves water and decreases urine production. ADH, if it is less, causes less absorption of fluid in the kidney tubules. Therefore, it increases urine output. Possible causes: first is genetics, either X-linked dominant trait or autosomal recessive gene. Second, it may result from a lesion, a tumor, or injury to the posterior pituitary gland, which compresses the gland and affects ADH secretion. Third is idiopathic or unknown cause. And fourth, it may be kidney-related, although this is rare. This is when pituitary function is adequate, but the kidney itself or the nephrons do not respond to ADH. Signs and symptoms of diabetes insipidus usually appear gradually. First is polyuria. with specific gravity of urine as low as 1.001 to 1.005. Parents will first notice bedwetting in an already toilet-trained child. Urine may actually reach 4 to 10 liters in 24 hours. The normal is 1 to 2 liters only. Also, this causes a very diluted urine. The specific gravity is low. The normal is 1.01 to 1.03. Second, there is polydipsia or excessive thirst, which is relieved only by drinking water, not breast milk or formula milk, since water is mainly lost in the urine. Third, there may be accompanying weight loss because of a large loss of body fluid. And fourth, there could be dehydration, especially if diabetes insipidus is untreated. It can result to death. Diagnosis: radiography, CT scan, or ultrasound can detect tumor in the skull. If this is present, it will warrant removal of the tumor. Next is through administration of vasopressin to rule out pituitary versus kidney disease. Vasopressin, as a review, is an endocrine drug which mimics the action of ADH. So if the cause is diabetes insipidus and it is pituitary in nature, the body will respond to this drug. If urine output decreases, therefore pituitary is at fault. But if kidney is the problem, urine will remain dilute and excessive. Management: surgery is the treatment of choice if a tumor is present. This will relieve pressure on the posterior pituitary gland and allow secretion of enough ADH. Second, if from other causes, can be controlled by the administration of desmopressin. Desmopressin can be given IV, per oral, or intranasal. It has a long duration of action, about 15 to 21 hours. You might be wondering why vasopressin is not mentioned here, as said in the previous slide. Vasopressin cannot be used as a dose or a maintenance dose for diabetes insipidus because it has a short duration of action, only 2 to 8 hours. So usually, desmopressin is the drug of choice. Syndrome of Inappropriate Antidiuretic Hormone, or SIADH, is the overproduction of ADH by the posterior pituitary gland, the opposite of diabetes insipidus, which is less or no ADH. This results in a decrease in urine production and water intoxication. As sodium levels fall in proportion to water, the child develops hyponatremia or a low sodium plasma level. Possible causes: CNS infections such as bacterial meningitis. It could be an effect of long-term positive pressure ventilation or mechanical ventilation. And third, it can also result from pituitary compression from edema or tumor in the brain. Because of excess ADH, there is weight gain, concentrated urine with increased specific gravity, nausea and vomiting, and as hyponatremia grows more severe, coma or seizures occur because of brain edema. As a management, restrict fluid because there is already water intoxication. Second is to give supplemental sodium by IV if needed because of the hyponatremia. And third, administer demeclocycline. It's a tetracycline antibiotic. It has a side effect of blocking ADH in renal tubules and reduces resorption of water. This drug can increase urine output. Congenital hypothyroidism is a disorder related to an absent or a non-functioning thyroid gland upon birth. This causes reduction of the T4 and the T3 hormones. T4 is thyroxine and T3 is triiodothyronine. These hormones are responsible for controlling the rate of metabolism in the body. T4 is our major and primary thyroid hormone, while T3 is a more potent one formed from conversion of T4 to T3. This disorder occurs 1 in every 4,000 live births and about twice in girls than in boys. Cause is usually unknown, although if a pregnant woman has hyperthyroidism, this can cause the fetal thyroid to not fully develop because at this time, the fetus is bombarded by the many maternal thyroid hormones, so there is no use of the fetal thyroid hormones. There are other types of hypothyroidism. The acquired hypothyroidism or Hashimoto's thyroiditis, but we will only focus on this congenital type. Assessment findings. The condition may not be noticeable initially because the mother's thyroid hormones may still be present at birth. Symptoms become apparent by about 3 to 6 months. First, there's altered body proportion, short and thick neck, short stature, and short legs. There is also hypotonic muscles and extremities, causing deep tendon reflexes to be decreased, and in the digestive tract, causing constipation. There is also delayed dentition or teeth is defective once it erupts. Fourth, there is an enlarged and protruding tongue, which causes respiratory difficulty, noisy respirations, or airway obstruction. There is also hypothermia with cold extremities. The skin is dry and scaly and does not perspire, and also the child sleeps excessively. Figure 48.2 shows an infant born with congenital hypothyroidism. All these findings mentioned here result because there is a slow metabolic rate from less thyroid hormones, and because it causes progressive physical and cognitive challenges. Early diagnosis of this disease is crucial. That's why in the Philippines, this is a part of the newborn screening program. Diagnostic and laboratory tests would reveal low radioactive iodine. Iodine is needed to combine tyrosine 4 and tyrosine 3 to make T4 and T3, which we get from foods that we eat, particularly seafoods or iodized salt. There is low serum T4 and T3 levels as evidenced by the insufficiency of the thyroid gland to secrete these hormones. There is also an elevated thyroid stimulating factor because the pituitary gland attempts to stimulate the thyroid gland to secrete hormones. That's its normal function. Blood lipids are increased because of less metabolism due to less thyroid hormones, and radiographs reveal delayed bone growth as evidence of stunted growth. Management is the oral administration of synthetic thyroid hormone sodium levothyroxine. A small dose is given at first, then gradually increased to therapeutic levels. This is taken indefinitely or for life. This is to supplement what the thyroid cannot make. While on thyroid hormone therapy, it's also important to give the child supplemental vitamin D to prevent rickets. Rickets is a skeletal disorder caused by lack of vitamin D, calcium, or phosphate. This is importantly given, especially when rapid bone growth begins. Again, with physical and cognitive challenges, It can be prevented as soon as therapy is started, but any degree of impairment that is already present cannot be reversed anymore. Congenital adrenal hyperplasia is a syndrome inherited as an autosomal recessive trait. The primary defect is the inability of the adrenal gland to synthesize cortisol. Cortisol is the primary glucocorticoid secreted by our adrenal cortex. Therefore, ACTH from the anterior pituitary gland increases to stimulate the cortex to function. Physiologically, the ACTH or the adenocorticotropic hormone from the anterior pituitary gland stimulates the adrenal cortex to secrete its hormone. So if the pituitary gland sees the need for more cortisol, its action to secrete ACTH increases. Although the adrenals enlarge, they still cannot produce cortisol. Instead, they overproduce androgen. Why? Because aside from cortisol, we know that the adrenal cortex also secretes other hormones. One is mineralocorticoid, which is primarily aldosterone, very similar in action to cortisol. And second are the sex hormones. The bulks, androgen, but some are estrogen. In this case, they overproduce androgen instead because of the increased ACTH production. Assessment findings. Children with congenital adrenal hyperplasia have increased levels of androgen, and this causes the following in males and females. Among the female child, it masculinizes them as clitoris enlarges and appears like a penis upon birth. There could also be a sinus between urethra and vagina. These may present an ambiguous genitalia. Labia majora and minora are fused and resembles undescended testes or hypospadias. Pubic and axillary hair and acne appear early because of too much androgen. There's also the masculine voice, and the epiphysis closes early. It prevents reaching adult height. Among females also, there is no breast development or menstruation in puberty because of the excessive androgen instead of estrogen. In males, size of fetal genital organs increases. By 3 or 4 years old, there's an enlarged penis, scrotum on prostate. The testes is not enlarged, so it appears small because of the enlarged penis. They have acne and a deep, mature voice that develops early, and there is no spermatogenesis, so the males are said to be infertile. As management, the child is given hydrocortisone orally. It's a corticosteroid which replaces what is not produced naturally. These may need to be continued indefinitely or for life. Because of this, the stimulation of ACTH now decreases and androgen will return to the normal level. The child needs periodic analysis of serum cortisol and growth measurements. This is to estimate the effectiveness of the hydrocortisone therapy. Congenital adrenal hyperplasia can also be detected intrauterine life by 6 to 8 weeks AOG through CVS or at 15 weeks through amniocentesis. If it is detected intrauterine life, dexamethasone can be given to the mother. This crosses placenta and prevents the fetal effects of increased androgen. Cushing syndrome is the overproduction of cortisol from the adrenal cortex. There could be two possible reasons. One, is because of increased ACTH production, because of a pituitary tumor, or because of a tumor of the adrenal cortex itself. The peak age is 6 to 7 years old, but it may occur as early as infancy. Diagnosis: dexamethasone suppression test. If without syndrome, giving dexamethasone, it's a glucocorticoid, will lower cortisol. It will not fall in children with adrenal tumors because the tumor continues to stimulate the adrenal glands to secrete cortisol. Second is cosyntropin or ACTH administration. Normally, cortisol will rise, but in patients with an adrenal tumor, the gland is already at full capacity. So no more cortisol elevation will occur with ACTH administration in a child with Cushing syndrome. Third is a CT scan or ultrasound result, which reveals an enlarged adrenal or pituitary gland, usually because of the tumor. Figure 48.4 shows a child with Cushing syndrome, and the manifestations are all because of the high cortisol's effect. Assessment findings. All these findings are because of a high level of cortisol. First, there is increased glucose production, which causes fat to accumulate in cheeks, chin, and trunk, causing a moon face stocky appearance. This also leads to polyuria as glucose finds its way out of the body through the urine. Second are catabolic effects which cause protein and muscle wasting, making extremities thin. This gives children a higher risk for osteoporosis. Third, steroids suppresses the immune system, leaving children susceptible to infection. Fourth, it also causes vasoconstriction, so extreme hypertension can occur. Hyperpigmentation also occurs from the melanin-stimulating properties of ACTH. Again, in this case, there could be high ACTH stimulation. This causes a child's face to be unusually red, especially red cheeks. Abnormal masculinization or feminization may also occur. This is because of overproduction of androgen and estrogen. Seventh, purple striae may result from collagen deficit and they appear on the hips, abdomens, and thighs. And lastly, the growth ceases, so there is short stature. Take note also that some children taking high doses of synthetic corticosteroids such as prednisone, for example, it's a synthetic cortisol. So these children may develop the same symptoms in Cushing syndrome. That's why sometimes the side effects of these drugs are said to have Cushingoid appearance. Children have Cushingoid appearance. Surgical removal of the causative tumor is the treatment for Cushing syndrome. First, if it is from the adrenal gland and the part of the adrenal gland is removed, the child will need cortisol replacement indefinitely. It is important to watch out for the signs of shock because epinephrine secretion is decreased from the adrenal medulla. This tends for the body to have problems maintaining blood pressure, and severe hypotension can result. Second, if it is pituitary gland, a part of the pituitary is removed, replacement of all pituitary hormones may be necessary for life. The prognosis of Cushing syndrome depends on whether the tumor is benign or malignant. Carcinoma of this type tends to metastasize rapidly. Diabetes mellitus results from damage to beta cells of the islets of Langerhans in the pancreas, which affects insulin secretion. As shown in the photo, insulin's function is to take in glucose from the blood, as glucose is needed for our body's primary source of energy. It simply opens the door to body cells. Without or insufficient insulin, glucose will just remain in the blood and cannot enter the cells. There are two types, type 1 and type 2. Generally, type 1 is caused by an autoimmune damage, while type 2 is not and related to many factors. Type 1 DM is absolute or relative deficiency of insulin, no insulin secretion at all. It's formerly called juvenile or insulin-dependent diabetes. It also occurs almost exclusively in children, onset at 5 to 7 years old, while type 2 diabetes has diminished or less insulin secretion from the pancreas. It's formally called non-insulin dependent diabetes mellitus and once thought to occur only in older adults, but now it is seen in overweight adolescents, termed as maturity onset diabetes of youth. Table 48.2 shows the comparison between type 1 and type 2 diabetes. Please go over them. There are three cardinal symptoms. First is hyperglycemia, as glucose builds up in the blood because it cannot enter the cell. Second is polyuria, as the body attempts to excrete excess glucose, the body also excretes a large amount of fluid. And third is polydipsia, as the excess fluid loss triggers the thirst response. A diagnosis of diabetes is confirmed based on finding one of the following three criteria on two separate occasions. Table 48.3 shows the acceptable blood glucose ranges for young children. First is a random blood glucose level greater than 200 milligrams per deciliter of blood. A random blood glucose test is taken anytime, irregardless of the last time the child ate. Second is a fasting blood glucose level greater than 126 milligrams per deciliter of blood. This is usually 8 hours without food, typically taken in the morning before breakfast. And third is a 2-hour plasma glucose level greater than 200 milligrams per deciliter of blood during an oral or IV glucose tolerance test or a GTT. GTT either involves oral or IV glucose administration. First step is to get blood glucose level drawn at fasting as the baseline. Then, after 1 hour of glucose, and lastly, after 2 hours of glucose. This is rarely performed in children because the test is difficult for them and tasking also for them to undergo. Management for diabetes mellitus is a combination of administering medications, diet, and exercise. First, when giving medications, it depends on the type. For type 1 diabetes, giving insulin in a combination of regular and NPH is a common maintenance dose. It is usually at 0.4 to 0.7 units per kilogram of body weight in 2 doses before breakfast and before dinner. Initially, at the first diagnosis of a child with type 1 DM, a short-acting insulin is given, such as regular or Humulin N for the first 24 hours. Then, an intermediate-acting insulin, such as NPH or Humulin N, is given in the second day. Afterwards, as a maintenance dose, the combination insulin is now given. Take note of each insulin's onset, peak, and duration. We have studied them in our pharmacology class already. Doses may also vary among different children. Remember also the different nursing interventions when giving insulin. 1. You always inject insulin subcutaneous, except in emergencies when half required dose may be given IV. Also, you have to rotate the injection sites subcutaneously. This is to prevent lipodystrophy. The injection sites are seen in the photo on the upper left. Third, when you aspirate insulin combinations in a syringe, always draw up the regular or the short-acting insulin first. Children can also be taught to self-administer insulin using an insulin pump, as shown in the upper right photo, and also self-blood glucose monitoring using a glucometer, as shown in the photo on the lower left, can also be taught for children, not just for type 1, but for children with type 2 diabetes as well. For those now with type 2 DM, giving of oral hypoglycemic drugs such as metformin is recommended. If not effective, may try to give sulfonylurea. Metformin decreases glucose produced by the liver and increases insulin sensitivity, while sulfonylurea stimulates the beta cells in the pancreas to produce more insulin. Second is to regulate a child's diet. There is also a possible need to force fluids, but without sugar. Third is to encourage regular exercise, but not through strenuous activities. Phenylketonuria, or PKU, is a disease of metabolism inherited as an autosomal recessive trait. Its cause is the absence of the liver enzyme phenylalanine hydroxylase. By the way, the last three diseases, PKU, maple syrup urine disease, and galactosemia, are all problems of different liver enzymes. Going back, these PKU is the absence of the liver enzyme phenylalanine hydroxylase, which prevents conversion of phenylalanine into tyrosine. What is phenylalanine? It's an essential amino acid from protein in foods that we eat. This phenylalanine must be converted into tyrosine, as shown in the photo. Tyrosine is a precursor of epinephrine, thyroxine, and melanin for the body to use. Because in PKU there is no converting enzyme, excessive phenylalanine builds up in the body. This causes permanent damage to brain tissue and leaving children severely cognitively challenged. For the assessment findings, normal phenylalanine in the blood is less than 2 milligrams per deciliter. A level of more than 4 milligrams per deciliter is high and may mean PKU. A measure of 8 and above is toxic to the brain. Take note also that PKU cannot be detected prenatally because phenylalanine level does not rise in utero. It only rises as children breastfeed from taking up protein. So screening for it may be done 2 to 3 days after birth, when the newborn has breastfed already. This is included in the newborn screening program. So what are the signs and symptoms? First, a musty or mousy urine odor. Phenylpyruvic acid, a breakdown product of phenylalanine, spills into the urine, which sometimes pervades not only in the urine but the entire child's odor. Second is a fair-skinned, light blonde hair, and blue eyes child. Tyrosine is necessary for building body pigment and is incorporated into thyroxine. Without it, the body pigment fades. Third, the child fails to meet average growth standards because of lack of thyroxine production from metabolism. Fourth, the child's skin is prone to eczema. There is a strong association between children with PKU and atopic dermatitis. And fifth, there are low IQ scores of 20 or less. There may be seizures, muscular hypertonicity, and spasticity. This is the goal of prevention of PKU, to prevent cognitive damage as phenylalanine is toxic to the brain. Management is placing a child on formula extremely low in phenylalanine, such as lofenalac. A small amount of milk may be added, or limited breastfeeding is also allowed, so child still can receive some phenylalanine necessary for growth and repair of body cells, but not too high. Second, as child grows older and have solid foods added to their meals, these foods also must be low in phenylalanine. Orange juice, banana, potato, lettuce, spinach, and peas. Child must avoid foods high in phenylalanine, such as those rich in protein, meats, eggs, and milk. The child is advised to avoid these high phenylalanine foods indefinitely for life. Third, the child may need their blood and urine monitored frequently for phenylalanine levels, making sure it does not reach 8 milligrams per deciliter. Fourth, hemoglobin levels should also be monitored if the child is becoming anemic, because iron is found primarily in protein-rich foods, which the child must avoid. If such cases and there is anemia, the child may be given ferrous sulfate. Maple syrup urine disease is a rare disorder inherited as an autosomal recessive trait. In this disease, there is a defect in the metabolism of the amino acids leucine, isoleucine, and valine. Again, because there is a lack of liver enzyme needed to convert them. This leads to degeneration similar to that observed in children with PKU. As a result, there is no normal breakdown of leucine, isoleucine, and valine as shown in the photo. So these amino acids and their byproducts build up in the body. And like PKU, it is toxic to the brain. Assessment findings: by first or second day of life, urine develops the characteristic odor of maple syrup. It is sweet smelling, caused by the presence of ketoacidosis. Hence, the name of this disease, maple syrup urine disease. Second, they appear well at birth, but quickly they begin to show these signs: feeding difficulty, loss of motor reflex, and irregular respirations. And then, they progress rapidly to opisthotonous position, generalized muscle rigidity, and seizures. These show CNS involvement. Unlike PKU, maple syrup urine disease can be detected prenatally through amniocentesis. If condition remains untreated, an infant may die as early as 2 to 4 weeks of age. First, important is to place child on a well-controlled diet that is high in thiamine and low in the amino acids leucine, isoleucine, and valine. If done on early first or second day of life, cerebral degeneration can be prevented just like in PKU. This diet is extremely difficult to maintain, so parents need intensive nutritional counseling. Second, hemodialysis or peritoneal dialysis can be used to temporarily reduce abnormal serum levels at birth or during a childhood infection. At birth, because high levels are evident, and during an infection, when catabolism of cells release increased amino acids into the blood. Third is to undergo liver transplant. This is the last resort, since problem is on liver enzyme necessary for conversion of the branch-chain amino acids. Galactosemia is a rare genetic disorder of carbohydrate metabolism that affects the ability to metabolize carbohydrate, particularly galactose. It is not related to and should not be confused with lactose intolerance. This is galactose intolerance. It follows an autosomal recessive mode of inheritance that confers a deficiency of another liver enzyme. It's the galactose 1 phosphate uridyl transferase. This liver enzyme is responsible for the breakdown of galactose into glucose. Looking at the photo, we ingest lactose in food, mainly from dairy products. This lactose is converted or broken down into glucose and galactose by the enzyme lactase. First is glucose. It is already used by the body for energy. The other one is galactose. The galactose needs the liver enzyme, so it breaks down into another glucose so that the body can use it for energy. But in galactosemia, the absence of the liver enzyme will prevent conversion of galactose into glucose. There is buildup of toxic levels of galactose in the blood and destroys many body cells. As soon as the child begins to feed, lethargy, hypotonia, diarrhea, and vomiting may occur. Liver then enlarges and cirrhosis may develop. There's also accompanying jaundice. Bilateral cataracts and cognitive impairment become permanent. The symptoms usually begin abruptly and they worsen rapidly. If the condition remains untreated, a child may even die by 3 years of age. Untreated children who survive beyond this time may have cataracts and be cognitively challenged. Diagnosis is made by measuring the level of the enzyme in the red blood cell. The erythrocyte galactose 1 phosphate level is as high as 120 milligrams per deciliter in a child with galactosemia. The normal is less 1 milligram per deciliter. Treatment is a lifetime diet free of lactose or galactose. Milk substitutes such as casein hydrolysates can be given. Once the child's condition is regulated on this diet, symptoms of the disease do not progress. However, any neurologic or cataract damage that is already present will continue to persist.